genomic profile allow us to allow us to make special targeted immunotherapies that are being done, especially in the West. They're extremely expensive. But anyway, so we'll just go through some of the things here. Um, so needle, this is going back 30 years and started with simple needle like all needles that we have. And it started with FNA. Um, but obviously we've come a long way in last 30 years. And our shift in the last almost decade has been from FNA to FNB completely. There's one thing that's important. There is still a role for FNA, and maybe it's worth looking at the cost profiling because I'll share my thoughts with you, which may be relevant to us depending on how what is the cost of FNA versus FNB needle. So third generation end cutting FNB needles you've seen being used. Acquire is one example. Shark core. Um, and then you have Mangini tips and three prong, which is Microtech. So the cheapest one available to us would be Microtech, and I think it works pretty well. As long as you have a system of assessing your tissue, you're okay. You'll get almost the same results with all needles. So here you can see FNA needles, which were obviously the initial ones, expect from Boston and then Columbus, etc. And then we move to the FNB needles, and FNB needles, the most common ones are Francine. It's based on the person who actually came up with this concept. And the idea is that you would have some sharp, in Acquire there are three like prongs coming out, and so it catches the tissue better than just a standard needle. Shark core is like this, so this is like a shark appearance, um, you know, and then you have the sonotip and then a microtip, which again is very similar. So concept is very similar. You have some sharp edges, and we are working on actually making our own FNB needles. We're almost there with the needles, and once it's established in our setup, making it commercially available is a longer journey. But I think it will be the cost difference at the moment if we use the same handle, which is not infected. Handle can be कुछ भी रहता है, everything comes in the needle. And we just replace the needle, the cost of FMP needle to us now is at the moment is going to be 1,000. And no, from the models to everything we are doing, I want it to be actually using all, at least public. Because when we make check, it's 6,000 rupees. And we made savory wire, it's 1,000. We don't, now we don't hardly use a second time. And so there's a lot of things that we can do, we are all capable of. Just when में आ जाए, you're given an opportunity. So back on the mic. Uh, what are the limitations of EUS needles? If you're going to do EUS and with FNA, then ROSE is very useful. Without that, it's not right. Can you do it without that? Well, you can, but you'll not be able to assess the tissue that well. So once you've got ROSE, now I'll tell you why ROSE has become easy, and then EUS FNA needles are much cheaper than FNB. Okay, so keep that in mind. And ROSE, with what we have shown you with the usage of technology, you can actually almost predict. So you can see cellular material, yes, on your road. All the slides you saw were made by techs in our unit. There is no cytopathologist technician with us. They're all our own techs. Okay. So, but still, you can. I think there's a role for USFNA when you're doing a pancreatic cyst, fluid aspiration, or you're taking samples from a very small, neural nodule. So you still have a role for that. So what are the recommendations? The recommendations are basically from ESGE. This is the latest. End cutting FNB needles over reverse bevel FNB or FNA needles. They have recommended that for tissue sampling of solid pancreatic lesions. This also applies to other solid lesions, although we don't have solid data for that. So with this, they have high quality of evidence as well. ESG suggests using end-cutting FNB needles rather than reverse bevel FNB or FNA needles for the histopathological diagnosis of autoimmune pancreatitis. There's a strong recommendation, but evidence is very weak here. So they have also had comparative comparison between different needles, and the bottom line is that Franson and fork tip needles, particularly 22 gauge, showed the highest performance for tissue acquisition. This is mainly in the pancreatic tissue, but probably applies to others as well. What are the importance of sampling techniques in improving the quality of tissue acquisition? The most something that everybody does is a fanning technique, and you saw it done many a time during this course. And the idea is that you're going, taking samples from different sites of different areas of the tumor or the target. And although it's very interesting, we use it for non-pancreatic, but there is really no literature support on non-pancreatic for fanning technique. So there is something that one can do. So they did these randomized controlled trials comparing fanning versus non-fanning, and everywhere you can see the dark are the fannings, and so the results are much better when you use fanning techniques. There are other methods as well. There's talk technique, which is very similar. The idea in talk technique is the same, but I think majority of the people I know use fanning technique now. So this is just for. So once you've got the needle in, you're doing fanning. How do you, what do you do? Do you apply suction? Do you do slow pull, or do you take the stylet out completely and just go? I think ESG recommends equally the wet suction or slow pull techniques for US FNB of pancreatic masses because they provide high rates of adequate samples and tissue integrity and reduce specimen bloodlines compared with dry suction. Now, this is where we've had this discussion that there is no real hard evidence to support one or the other. Just do what you do. I personally feel that you do something because you're doing regularly. You see what is good for you, and you just stick to it. As long as you're getting good samples, that's what matters. The idea here is so. What is slow pull? You have a stylet as you're going in and out, the stylet is being pulled by by your nursing or technician support. So the idea is that it's actually creating a negative suction, so the tissue is actually coming in. Slow pull is that no suction. Basically, is that you take the stylet out and just keep going in. Dry suction is when you attach a syringe which has a vacuum or suction capability, and you just attach it to the syringe and it creates that negative pressure. The problem is that it usually brings more blood as well. So it's a little bit more bloody when you do dry suction, if the tumor is vascular, obviously. Wet suction is you prime the needle with water, okay, and you put 2 cc's saline in your syringe, and actually the concept is that as the water is being pulled into the syringe, again, a vacuum is created or a negative pressure is created so that the tissue can actually come in. All of these are, as Khalid the other mentioned. So, how many times do you have to actually do to and fro movements, number of actuations? Again, there is a trial which has looked at different numbers, and what they've come up with is that 15 is better than 5. But overall, there's not very hard evidence to support. One thing that is recommended is that anywhere between 10 to 15, and I think that's probably what most people end up doing even before you realize. Um, and each to and fro movement should ideally cross the entire diameter of the tumor. I think that's important. If you're going through the tumor, you just don't want to go in a little bit, come out. You make sure you literally go to the end, come back, and then go and come back. And the way, sorry, I think fanning हमने आपको दिखा दी थी. It's basically the elevator and the big wheel. Those two are used to actually change the course of your needle. Number of passes, I think there's consensus that it should be at least 2. Okay, if you've got good tissue in 2, then that's good enough. Otherwise, you go on till you get good tissue. So, specimen handling and processing, dimensional space, cytospins, LBC, as long as you've actually spoken to your lab. And what we've done is we got the lab guys, because we don't have a lab here. Like, they have literally a cytopathologist sitting in their office, and a cytotech as well, and they've got the labs very close. I think it's important that you bring the lab guys, make sure you're collecting the specimen correctly and in the correct container, because I've seen that has been a big problem. Slide making is very simple. Actually, I first went to the course in Florida. And that's where I had that session, and they actually made us uh, make slides. And then I came back and I said, well, so we got the cytotech here for 3 days, 3 or 5 days from Shogul Khan. And then we went through slides. We had 2 techs who we trained, and then we were okay. So when you're dealing with pancreatic cyst fluid, uh, volume less than 0.5 ml, biochemistry or molecular testing with cytology, and for volume more than 5 ml, cytology, biochemistry. I think the most useful test now for the sample is your glucose, where you can do CEA and obviously you can do amylase where you suspect. Molecular testing, I think you can collect the sample, and there's a company here that sends it abroad, but the cost obviously is a major issue. Do we need rapid on-site evaluation for FNB? And general consensus, you don't need it. But a lot of centers who already have established rows continue. We also continue. I think it's just that I think that part is very useful for us for not only this, but for cytology, doing bile duct cytology or spy bites. We do touch smears, and that's it's good to see that again. Khalid was here, and I asked him, their brush cytology results are better than obviously quite a lot of centers, and they do that correctly. Yeah. So these are they've looked at it, and we've already discussed this. Now this is important. We've seen this only yesterday. So the slides we made, put it on ChatGPT and actually describe the whole slide. So there's room for obviously AI here. There's room for you because we have a Wi-Fi connected microscope, so we can actually send the samples even if you want to their center through Wi-Fi, literally almost as we are looking at it. If you have a cytopathologist available, you can actually do that. So now that's where we were discussing FNA needle. Making FNA needle is the easiest. FNB is obviously technically difficult. FNA is not a problem. Now, if FNA needle is very cheap compared to FNB needle, and if you have rows, FNA needle would probably give you almost similar results. So if you are really stuck with cost and we are not getting FNB needles in our part of the world, then I think doing and using FNA needle with rose may be an alternative, but a much cheaper alternative because the cost of FNA needles will keep going down. So this obviously makes it. So you've heard these terms, macroscopic on-site evaluation, where you're actually measuring the macroscopic tissue um, that you've obtained. Then you have different types. Obviously, the less bloody, the better, but depending. So, for example, neuroendocrine tumor would have more mixed because it's more vascular versus pancreatic cancer, where you'll get this. Sorry. Visual on-site evaluation is just looking at the same thing, not measuring. But if you've looked at it and you think the sample size looks about a centimeter, which is this much, then it should be good enough. And they've actually quoted 4 mm as well. But in our experience, the small samples almost always the result comes back not enough. 4 mm, there's very unlikely that I would get from the. So, but this is something that you also saw. That's a stereo microscopic on-site evaluation, which is that little camera that gives you 30 magnification into 30. So actually, you can see the core mixed with blood or otherwise much better. So I think it's not a very expensive thing, and it's probably worthwhile if. SOS is basically using this device. You saw that, it's a microscope, stereo microscope that only gives you slit magnification. So, are there other techniques that help us? Yes, contrast enhanced EUS. Randomized trials haven't shown any real advantage. Not many people I know use it other than maybe trials or studies. Uh, may have role in specific cases. Maybe DFI again, is a technology that's within the scope. And EUS elastography. This comes as a package in your endoscopy system, ultrasound system that you buy. The processor has this built in it. Now, the cost of this particular processor versus if you don't have these is quite significant. So you have to really see whether you need these in your routine practice or not. And I'll have, at the end of the talk, I'll have opinion from Mustafa and Khalid and Deem. But I don't think I know many people who have actually had much benefit from these. Maybe there will be a time to have really look at it. So what do you do with pancreatic cysts? We've already touched on it. So if you're going to just aspirate, it's always good to aspirate with 19, especially if you're thinking that there's going to be thick fluid there. And mucoid fluid is not easy to come out with 22G, so 19 is better. And this is where USFNA still has a role. What do you do with liver biopsy? 19G is better than 22G, FNB rather than FNA, wet section rather than slow pull, heparinized needles, use stylet to keep specimen intact. single pass with 3 actuations. This is what is recommended, but you make 2 passes. If you don't get tissue, what do you do? Needle straight while disengaging from scope. That's very important, and I'll show you a video. That's Dr. Khalid's video. Tissue express slowly with stylet over tooth. This is very important. Keeping your needle straight and bringing it out slowly. Because you want that core to come. So hopefully this will play. Yes, it will. So I borrowed this from Dr. Khalid. So you identify the easiest is obviously left lobe, as we discussed. So you can see the needle coming out. And again, fanning 4 to 5 times. See, the advantage of holding the needle like this, and we'll just show you, that you have more control. But you can see the liver is up to here now. So you've got a nice passage. You need to make sure there's no vessel. Now this is important. मैं इसको आप बात कर लेते हैं. I wanted you to see. देखो, they're keeping this almost straight. So now you're keeping that end straight and very slowly advancing the. That's a nice score, and even you can see it obviously with the. Once you've got a core that's that long, I think you're comfortable that you've got reasonable. So right lobe, you need to go where? How will you get the right lobe? So this is what this course has done. You don't have to think. You know now where you are going to go and do what. It's important, obviously, you want to select an area where obviously there are no vessels. Although again, when they're doing ultrasound guided liver biopsy, they're not actually they don't have a three-dimensional thing. So they will be going through the vessel, and the patients are not so much affected, maybe because the liver parenchyma is such that the feeding is compressed as it occurs. I don't know what it is, but well, Mangini is what I used to use. So the rest of the things are same. Okay. So what are the advantages? I think if it wasn't for cost, um, I would think this is probably a better way of doing liver biopsy, but obviously this is very expensive. More comfortable experience. Most patients don't have any pain. Ability to do biliver biopsies, real-time imaging when you're doing biopsy, comparable or better than percutaneous or transjugular. Adequacy for pathology interpretation nearly 100%. So you get enough portal tracks to see if you've done it properly. So I think if it wasn't for cost and I wanted to have a liver biopsy, then I would probably ask you to do an EUS guided. But I think cost is seriously prohibiting, especially with the amount of liver disease we have in our country. What about lymph nodes? Again, very good sensitivity and um, positive predictive value, specificity, accuracy, and negative predictive value. And the new needles and cutting needles, safe method, valuable, good core. The high quality of histological cores and the good amount of tissue allowed to complete immunohistochemical analysis. So the problem with lymph nodes is you really want good tissue so that you can properly assess the tissue and differentiate between different lymphomas. So genomic profiling in pancreatic cancer is important, biliary more and more important. Bile duct cancers have alterations that can be assessed and then can be targeted. The bottom line is what I think is important. About 18% of patients undergoing CGP exhibited potentially actionable mutation, highlighting the potential for personalized therapeutic approaches. Now, we are a little away from that. However, if you want it, there is a system of sending sample if you want to, but there is prohibiting costs for assessment and also for obviously treatment. Immunotherapy is extremely expensive. This is a new thing. I have no experience with this. This is through the needle biopsy forceps. Good for cystic walls, they say, but I personally have no experience. So Khalid and Mustafa and Nadeem may have used it. And what about digital confocal laser microscopy? Again, I think it's not really in use in most centers. And I know that Mustafa and Khalid have used it, but I didn't get a very good positive. Yeah, but okay, so bottom line is you have a pancreatic solid lesion. Pre-procedural assessment is important. So you need to know what you need, what is actually required here. So lesion assessment. And then when you come down to doing the procedure, FNB needle, if it's available to you, any of the Francine or fork tip actually is whatever is available is pretty good. 20G is preferred. 25G usually where when you're in the D2 and you're trying to biopsy from there, sometimes it's difficult to bring the 22G needle out. And if you feel that, you can use 25. Otherwise, I don't. I mean, I don't. I've not used 25. And most of the D2 as well, we can almost always do 22G. So 22G is the size. FNB, any end cutting needle is probably the same. Technique is fanning, almost universal now. Well, whichever technique of actually taking the tissue out, whether you do wet suctions, dry suction, slow pull, or without the stylet, I think it's something that will vary from person to person and their experience. Two needle passes should be the minimum, and if you have rows, I think it's a good learning exercise, and it's something that I would recommend. It doesn't really cost us, but this is modified rows. Actual rows, you need to have a cytopathologist assess at the same time. But now I think with the newer technology, you can actually bypass that. With that, thank you very much.
Extend it a little bit out. So the lower part, the lower thing, when and how should we adjust that? The upper is for the needle to come out. Yes, yes.
Fresh from the, if you're needing and using a fresh needle first time, then you don't need to adjust anything. You just go in, target your lesion, advance your needle. If you feel any resistance in the needle, there is a problem. You should not, you don't need to push. It just literally goes without any resistance. I, if you're doing it second time, when somebody has actually moved it, it's important to check whether your sheath is out or not. Sheath should be a little bit out for your needle to actually go smoothly. You can actually see it on EUS as well as endoscopically. If you are reusing
So the principle is that you need to know where your sheath is in relationship to the probe and the lesion, right? The different needles come out preset at different settings on their sheath based on how they're packaged. And you need to know the distance for that needle for when it comes out and also where it will come out of the needle channel. The safest thing, and I usually teach the fellows to do this, is to pull it back to about 1 centimeters outside. And actually, under EUS guidance, open your elevator and advance the sheath first and visualize the sheath. Especially early on, there's a tendency to just quickly get it down and puncture. But slow yourself down, visualize the sheath, because once you see the sheath, there's more of a chance to see the needle. Otherwise, if you're not seeing your sheath and you start puncturing, and you're like, I'll ask the fellow, so do you see the sheath? And they go, yes. And I go, where is it? And then they point to something which is not the sheath. You have to see clearly those two parallel lines to know that that's your sheath. And you have to, this is mandatory 99% of the time. Once in a while it's okay, but 99% of the time you have to see the needle come out, go into the lesion, come out. You cannot have your needle go in and out. And fellas have this tendency that, oh, I'm in the lesion. I go, how do you know? And then they turn their scope a bit and they're actually outside the lesion. So the principles are, this is a visualization based biopsy. This is not a, my sheath is out, my needle's out, so I must be in the lesion. Okay, so I would recommend that you set it back a bit. In my cases, for everybody who was in the room yesterday and day before, I was actually taking the needle and I was unlocking the sheath and pulling it all the way back to 0, locking the needle on the scope, and then advancing the sheath with the elevator open, visualizing the sheath, locking it, because that distance can vary whether you're in duodenum, stomach, esophagus, and then advancing my needle. Okay? So you have to be precise and make a conscious effort to look at your sheath.
And sometimes even when we are doing for the first time, we find some resistance
Pull the
during
sheath
the
back.
passage.
I I would suggest early on consider pulling the sheath back to 1. Usually it's going to be more than 1, 1.5 to 2, but pull it back to 1. And just like in ERCP, open your elevator, have it locked. Now open your elevator and advance the sheath. And with your elevator, you can actually move it up and down to see the movement of the needle tip or the sheath tip. And that's how I think you can overcome that resistance.
So, what is the function?
What we'll do is make it even more. We've got still a case to do, and what we'll do is we'll show you the sheet um, where how it looks, and how much do you want to keep out. Shoulder movements is the only thing is that you want to see the needle, you can't see the needle move your shoulders. One way or the other, you'll see the needle, but I think it's very important that you need to know where your needle is before you start actually doing multiple movements and find out you've got the wrong place.
Sir, what is the function of this stylet actually? Because I've seen if you are doing for the second time, where people, I mean, Dr. Khalid and some,
That's
they
the function
do
of
not
stylet.
even use their stylet.
Okay, the principle I think is that stylet goes and covers that area So you're not getting any tissue till you're going in, right? And so once you're actually where you want to go, you just want that tissue to come. But like you said, there are people who style it out completely and then do it from day one. I mean, I don't think it makes I really don't think it makes a difference.
It's not my things that are the time correct. You need to know your needs. Every needle works, but you need to know your needs. Yesterday we talked about the stylet, which has got a blunt end, and then the stylet, which has got a tapered tip. So this needle, which is a fairly new needle, it has the advantage of it improves your functionability. So it's got sharpness here and obviously sharpness at the tip. Now, the reason people would want to have this stylet in place is because sometimes this cytopathologists, at least in our practice, would want us to document on the report that this was a sample obtained transduodenal or transgastric biopsy. Because there are certain passenger cells. So if you're going through the wall of the stomach or the wall of the duodenum, you're going to catch some cells from the wall of the stomach and wall of the duodenum. So where are you actually puncturing the needle from? Is it transgastric or was it transduodenal biopsy? It has implication in certain cases. For example, if there's a case of IPMN, is it gastric type or is it not a gastric type? But if you've gone through the stomach wall, you're going to completely confuse your cytopathologist. So they're looking under the microscope. They don't know where you're taking this specimen from. So advantage of having a stylet in the first pass is when you puncture, so you pull it out, make sure this blunt end is back, and your needle is now ready to puncture. Once you have punctured it, then you push it in so that you get rid of the passenger cells. And then you take a specimen. After first pass, you don't actually need to do it, so you don't actually need to have it again. However, in certain needles, there is a needle called pro-core needle. So when you're actually going in and out of on the eoscope, you actually see the needle. There's a bit of a gap, and then you see the tip, or a bright dot, which is actually the tip of the needle. Okay, so needle itself, bright light, a gap, black, and then the actual tip. That's the actual tip of the needle. So you keep going in and out. There's a pro-core needle, and the gap between, so this is the needle going in and out in the lesion. Needle, gap, and then there's a tip. That's what you're going to see in the pathologic lesion. Okay, that's where the tip is. With the pro-core needle, this gap is quite big. And this is the part of the needle itself which is weaker. Because if you look at the design of the needle, in some cases. I mean, so the field emissions, for example, in the chronic pancreatitis, there are some very hard pancreatic masses. You can't actually differentiate. This is just a mass forming chronic pancreatitis, or actually a lesion, which is quite hard and can be. And sometimes they want us to obtain as best sample as possible. The other condition is the problem. You get very when you do it. I mean, the data doesn't actually support that. Data doesn't support that. But this needle is out there, and some people may use it. But to remember that especially using this pro-core needle, this is the area which is quite weak. So if you go in without the stylet, this area gets very easier. So you need stylet every time you go in if you're using a pro-core. The others you don't need unless you've got a concern that you really don't want any passenger cells in your specimen. Those are the two situations where we would want to have a stylet, but otherwise you don't actually need it. That's kind of my experience.
Yeah, so beside that, when the needle comes from the factory and the stylet itself maintains the shape of the needle too. So it gives us support. So that's why they put that one. And second is expressing the specimen. Beside all that, what's been said, these are the two other reasons. Because when you use a syringe to express it, it just splashes. When you use a stylet to push that specimen out, it maintains the core. So these are the other two reasons. And some of those, like I said, Nadeem's mentioned, that stylet is sharp, helps you puncture it. Others are really protecting the sharpness of the needle as well, because they go beyond that. So you have to here one of those. I think you made that picture there, right? Stylet. Oh yeah, right here. You see this? The stylet. Stylet itself is blunt. but it's going beyond the sharp edges of the needle. So that protects the sharp edges of the needle. But in this, you have to be careful when you're doing that. You have to remember that before you puncture it, you need to pull the stylet back. Otherwise, you're trying to puncture it with the blunt. And so that's why sometimes what happens is like in a core needle, acquired needle, you need to pull it back. Because otherwise you may have a problem puncturing that. So if that's the case, and with about the, I think Mustafa already kind of stressed that about the sheath itself. Need to know the sheath when it comes out of the scope. It should be out of the scope because if the sheath is inside the scope and scope is at an angle, you're trying to push the needle through that, it's going to puncture your scope. Okay. So it's, you need to see the sheath, and sheath does not need to be too far out there, because too much out there, the elevator is not going to give that fulcrum effect. Like a little bit out, and that makes your helps you move your needle up and down much better. Like for a fanning technique, changing that direction. If it's a small lesion at an angle, uncinate process, sometimes you need an elevator to get to that. And some sheets are plastic, other is a hard plastic, some is like more like a flexible metal. So different, every needle has a different sheet. If it's a shark core, it's plastic. If it's a easy shot, which is a Olympus needle, that has a very, very nice outer sheet at least. And that does not get affected with the elevator. It's more like that Carlock needle. It's kind of that kind of a material of the sheet. But one thing is, Mustafa already mentioned, some are at 1 centimeter, other they come at 2 centimeter, that lock. But once you open the sheet like that lock, make sure that you lock it really well. Because when you're doing that stabbing, if it is not locked, the sheet is also going to go in, and it's going to cause really complication. Okay, so that is very, very important. Once you manipulate it, open it, before you get the needle, push the needle, make sure it's really, really locked and it's not going to move. Other problem happens is once you open it to adjust it, sometimes it's not one-to-one movement. Okay. And when it's not one to, like you may, the way I do is I push that sheet out, okay? And if you try to pull it back, almost sometimes 1 centimeter, the handle comes back, but nothing happens to the sheet, okay? So just push that out a little bit, and then gently pull that handle back, and then move it in slowly until it gets to the sheet and sheet starts feeling that handle again. Because and then lock it there, because if you don't lock it there, there's going to be gap and sheet's going to come back. Okay, so there are like these little bit nuances you need to be aware of that, and that comes with sticking to, if you're doing a lot of these cases and use different type of needles, you will get familiar with those needles. But if you have only one needle or two needle to use, you need to understand the mechanics of the needle. You need to understand the whole structure of the needle, sheet, material, how it's going to get affected with the use of elevator. Is the stylet sharp? It's blunt? Is it going to be, when it comes, is it outside? Is it protecting the sharp edges or not? So just whatever you're familiar with, just study that needle. Okay, because you, here in this country, in this setup, you're not going to have access to every needle. You have to pick one or two, at the most, probably one. For us, all those needles are available. And because there are so many of us, and each has a different preference of using, I usually say all these needles out there, they all work. You just need to figure out how it works and how it works for you. Okay.